Welcome to this explainer. Today, we're diving straight into the incredibly high-stakes world of muscle-controlling drugs. We're going to take a journey, starting right in the intense, precision-driven environment of the surgical operating room, and we'll go all the way to the daily realities of the outpatient clinic. If you've ever wondered exactly how modern medicine commands the human body to stay perfectly still, or, how it manages to calm a relentless muscle spasm, well, you are absolutely in the right place. Let's get into it.
We've got a total goldmine of life-saving medical pharmacology to go through today. We're going to decode this step by step, transforming all these complex drug classes into a really clear, logical narrative. By the end of this, you'll grasp exactly how these critical medications are working right down on a cellular level.
Here is our game plan for today. First, paralyzing the muscles. Second, depolarizing versus non-depolarizing blockers. Third, the malignant hyperthermia crisis. Fourth, reversing the blockade. And finally, skeletal muscle relaxants.
Section 1. Paralyzing the muscles. Precision in the OR.
Picture this. You're in the operating room. The surgeon is doing a delicate procedure, or maybe the patient requires mechanical ventilation. Any sudden muscle movement? Yeah, that could be completely disastrous. So, to get this necessary paralysis, neuromuscular blocking drugs are deployed. And the absolutely crucial takeaway here is their unbelievable specificity. These drugs specifically target the nicotinic receptors, and a good way to remember that is the M literally stands for muscle. They act right at the neuromuscular junction, exactly where the nerve meets the muscle fiber, while carefully avoiding the NN receptors. So what does this mean for us? It means we can shut down skeletal muscle movement without completely crashing the patient's autonomic nervous system. Pretty wild, right?
All right, Section 2. Depolarizing versus non-depolarizing blockers. Two different paths.
Let's look at the depolarizing blockers first, famously represented by succinylcholine. So succinylcholine acts as a strong agonist. Think of it kind of like jamming a key into a lock, turning it, and then breaking the key off so the door just stays permanently open. It produces this sustained depolarization that essentially exhausts the muscle, totally preventing any further contraction. On the flip side, we have the non-depolarizing blockers. These are the drugs with the suffix curium or coronium, like Atracurium, Rocuronium, and Vecuronium. Their logic is a lot simpler. They're competitive antagonists. They literally just plug the keyhole, blocking the receptor entirely so the body's natural neurotransmitters can't even get in to activate it.
But, it makes you wonder, what happens when a totally routine administration of succinylcholine, or even a standard inhaled anesthetic, actually triggers a hidden, deadly genetic trap in a patient?
Which brings us to Section 3, the malignant hyperthermia crisis, a high-stakes emergency. We are talking about an absolute clinical nightmare in the operating room, malignant hyperthermia. It's this incredibly rare but totally life-threatening hypermetabolic condition. It happens when a susceptible individual is given succinylcholine or potent inhaled anesthetics. We're talking about those fluorane drugs like sevoflurane, desflurane, or isoflurane. Now, susceptibility to this terrifying state isn't just random bad luck. It is heavily linked to inherited autosomal dominant mutations, or sometimes new de novo mutations in very specific cellular receptors. Let's walk through exactly how this crisis builds, because it's intense. Step 1, it all starts with a genetic mutation to the ryanodine receptors, specifically RYR1, or the dihydropyridine receptors, DHPR. Now, normally, the patient has absolutely zero clue they even have this mutation. But then, step 2, the trigger drug is introduced. This causes those faulty receptors to malfunction and just dump a massive amount of calcium from the sarcoplasmic reticulum straight into the muscle cell. Moving to step 3, this sudden flood of calcium forces the muscles into a dangerous, unrelenting, sustained contraction. And finally, step 4, we see the devastating cascade. The body's metabolism just goes into complete overdrive. The patient develops hypercapnia, which is way too much carbon dioxide in the blood. Their heart rate shoots up, tachycardia. You see severe masseter and generalized muscle rigidity, muscle breakdown known as rhabdomyolysis, and of course the incredibly high fever that gives hyperthermia its name.
Okay, Section 4. Reversing the blockade. Restoring control.
Whether a routine surgery is wrapping up or we're suddenly trying to manage a major complication, we absolutely need to know how to effectively reverse these chemical blockades. So the crucial thing to understand for reversing a depolarizing blockade like succinylcholine is that it has two distinct phases. During phase 1, the prolonged depolarization phase, there is no antidote. None. Actually, if you try to give a cholinesterase inhibitor to reverse it during phase 1, you will literally potentiate the block and make the paralysis worse. It's not until phase 2, when the receptors are repolarized but desensitized, that cholinesterase inhibitors might actually be used for reversal. And beyond malignant hyperthermia, you've also got to watch out for severe complications like hyperkalemia, which is a really dangerous spike in potassium, and hypercalcium. Plus, there's this unique risk factor. Some patients have a pseudocholinesterase deficiency. Basically, they just lack the enzyme needed to break down succinylcholine in the first place, which leaves them paralyzed for much, much longer than anyone planned.
On the flip side, non-depolarizing blockers, those competitive antagonists we talked about, are a whole lot more straightforward to reverse. They have clear antidotes. You can use a direct reversal agent like Sugammadex, or you can go with cholinesterase inhibitors like Neostigmine. But check this out. This is where the pharmacology gets incredibly elegant. If you use Neostigmine, you are increasing acetylcholine everywhere in the body, not just at the muscle. This means you absolutely must co-administer an anticholinergic drug like atropine or glycopyrrolate. Why? To protect the patient's heart. Without atropine blocking those muscarinic receptors, the sudden surge in acetylcholine would cause severe bradycardia, plunging the patient's heart rate to super dangerous levels. It's just a perfect example of how we have to counterbalance drugs to ensure patient safety.
Section 5. Skeletal muscle relaxants. Moving to the outpatient clinic.
Now let's step out of the high-stakes operating room for a second and trace through the major relaxants used for everyday spasms. It's really fascinating how diverse their mechanisms actually are. Look at Baclofen first, a GABB receptor agonist acting primarily in the spinal cord. A really easy trick to remember this: Baclofen acts on the back. It's highly effective for severe muscle spasticity, dystonia, and multiple sclerosis, though, it often causes sedation. Then we have cyclobenzaprine. Instead of the spinal cord, it acts higher up in the central nervous system, mainly right at the brainstem, to treat acute muscle spasms. Interestingly enough, it's structurally related to tricyclic antidepressants or TCAs. That perfectly explains why its major side effects include anticholinergic issues and, again, significant sedation. Finally, we've got Tizanidine, which acts centrally as an alpha-2 agonist, making it really useful for MS, ALS, and cerebral palsy.
And this brings everything perfectly full circle. Remember that malignant hyperthermia crisis we covered? Well, meet the hero drug, Dantrolene. It is the direct, life-saving resolution to that nightmare scenario. Now, unlike the others that act on the brain or the spinal cord, Dantrolene acts directly on the muscle itself. It specifically binds to and inhibits that mutated ryanodine receptor, literally slamming the door shut on that lethal calcium release from the sarcoplasmic reticulum. It is, for all intents and purposes, the ultimate pharmacological brake pedal for a hypermetabolic crisis. As we wrap up this explainer, I really want you to think about the incredible precision, but also the inherent risks of modifying human biology. I mean, we've seen how we can temporarily sever the brand's control over the body with a simple competitive antagonist, right? But we've also seen how just a single genetic variation can turn a routine surgical paralytic into a massive, life-threatening crisis. It really leaves you wondering about the sheer power of pharmacology. What other genetic secrets might our receptors be hiding just beneath the surface, just waiting for the right or wrong trigger? Thanks for exploring the depths of muscle control with me today. Keep asking questions and keep learning.